So there's a lot of activity going on with PCSK9 inhibitors at the moment. We've seen a lot of clinical trials that have looked at the lipid-lowering effects of these new monoclonal antibodies. But as we've moved forward with these large clinical event outcome trials, which are really trialling the effect of a monoclonal antibody against PCSK9 on top of treatment with a statin in patients at a high risk for cardiovascular event, the question is, what else do we know about what's going on in the artery wall? We've seen some early studies that have just recently been reported in mice that suggest that if you inhibit PCSK9 on top of a statin, there does appear to be a favourable effect, not only on the size of the plaque, but potentially more importantly on the composition of the plaque. And so plaques that remain look less inflamed, and as we know, inflamed plaques are the ones that tend to cause heart attacks and strokes. And so we think that would be a good thing. We've translated those results into ongoing trials that are using arterial wall imaging. We use coronary intravascular ultrasound to look at progression of atherosclerotic plaque within the coronary arteries in humans, and are currently performing a study called GLAGOV, in which we're evaluating the effect of a PCSK9 inhibitor on progression of coronary atherosclerosis in patients who have coronary disease who are treated with a statin. So that'll give us really important information that will really tell us what is PCSK9 inhibition, what is it doing to the biology of the artery wall, and that will be an important complementary information to ultimately what do these agents do to cardiovascular events. So our current approach to really both primary and secondary prevention of our patients is really based on this kind of amalgamation of kind of traditional cardiovascular risk factors, blood pressure, cholesterol, diabetes, smoking, for example. And we know that by targeting those traditional risk factors, that gets us part of the way, but there's a big residual risk. There's a lot of activity in the secondary prevention space, but we know that, in fact, most individuals out there who are at a risk of having a cardiovascular event have yet to come to attention. And so one of the really intriguing concepts that's come up in more recent years is, can we use artery wall imaging to help us with risk assessment? We can use a range of non-invasive imaging approaches, ultrasound of the carotid arteries, we can do CT scans of the coronary arteries looking at either the calcium load or plaque burden. And would that help us in terms of the ability to see evidence of subclinical atherosclerosis? Would that be more likely to make a doctor prescribe intensive lipid-lowering therapy, for example? And we know that from observational data, it suggests that that would be the case, that if there's evidence of plaque, whether that's an elevated calcium score, an increased carotid intermedial thickness, for example, that those findings do tend to make doctors more likely to prescribe risk factor modifying therapies. And so, as we move forward and imaging becomes more available and hopefully cheaper, one of the important questions will be, how do we integrate that to our clinical practice? Will doing imaging change what doctors do? Will it change what patients do in terms of compliance? And will that ultimately kind of translate to improved cardiovascular outcomes? So one of the questions that comes up with regards to in which patients might imaging subclinical atherosclerosis be particularly important, and the types of individuals we think about are clearly intermediate risk individuals where we think the presence or absence might either make us more likely or less likely to initiate therapy. But then we also think of specific subsets of individuals who we think are probably at a very high risk early on in life. So familial hypercholesterolemia, for example, is a really good case example of individuals where there's a lot of discussion right now. Can we use imaging, and will that help us decide when we're going to start initiating more aggressive lipid-lowering therapy? We know that we're going to start lipid-lowering therapy in all of these individuals at some point in time. Would the presence of plaque really kind of sway our opinion to be more aggressive and more aggressive at an earlier stage? And as I said, I think there's a lot of discussion in the FH community right now. We know that a lot of our colleagues who are treating FH patients are already starting to kind of adopt that kind of approach. And I think that it will be important to start to put that evidence together and help us try and get some sort of consensus in terms of how we use imaging of the artery wall, whether it's ultrasound of the carotid arteries, whether it's CT imaging of the coronaries, and how that helps us decide in whom we're going to be more aggressive.